Naruvi Hospitals, promoted by the Sanko Foundation, is the brainchild of the founder-chairman Dr. G.V. Sampath. Belonging to Vellore, the medical hub of India, Dr. Sampath's vision to create a medical destination for the people of Vellore in particular and others from India at large and also overseas resulted in the establishment of a hospital here, a real crown jewel in the field of healthcare. Large numbers of people belonging to Vellore and the surrounding districts have been known to travel to Chennai and Bengaluru, both nearly 200 kilometers away from Vellore, seeking medical care due to the dearth of facilities and the hardships faced by the locals to access available services. As per the vision of the chairman, the best in healthcare, both in terms of medical and nursing professionals as well as sophistication, were infused into the institution, making sure that patient affordability was addressed at all times. Less than a month after Naruvi Hospitals opened its doors to the public, the second wave of COVID loomed large as life. We took on the challenge and quickly rose to the occasion, catering to the local population and some from outstation as well, adding close to 40 critical care beds and over 200 ward beds to the COVID care pool. Much as it was hard for a 1-month-old hospital to handle such large volumes of very sick patients, Naruvi Hospitals was able to contribute significantly in our country's efforts to save people from the disastrous end that COVID was driving people to. Naruvi Hospitals is positioned as a high-end tertiary care center. Our focus on ethics, transparency, patient satisfaction, and an academic outlook in everything we do ensures that doctors, nurses, and others in the care team are performing at their conscientious best to not only treat patients' ailments but also to make them happy overall when they leave our hospital. We have tied up with the Henry Ford Health System, HFHS, based out of Michigan State in the United States of America. HFHS is one of the old and leading healthcare delivery systems in Midwestern America. The main aim of this tie-up is to have constant transfer of knowledge and to get access to the time-tested practices they have been following for decades, which ultimately translated to patient care. Naruvi Hospitals is a completely paperless and filmless hospital. The Naruvi philosophy of care is embodied by our motto, Fragrance of Care. The doctors in Naruvi are largely trained in the best of medical institutes in India and come with years of rich experience in their fields of expertise. With the philosophy and its pallbearers, the medical and nursing professionals, the high-end equipment, and the building infrastructure complete the holistic picture of Fragrance of Care. The hospital is 475 bedded with a 25% critical care bed count. Naruvi Hospitals boasts of an over 5 lakh square foot building spanning 14 levels. The building is completely air-conditioned, conforming to ASHRAE standards with zone-specific air conditioning to reduce cross-infection between different care areas. Our laundry is 100% barrier washed. We have a top-of-the-line sterilization department with machines with 95% water-saving machines, saving up to 300 liters of water every running hour. We have all the major medical and surgical specialties. There are 16 modular operation theaters with laminar airflow. All the equipment in the ICUs and OTs are pendant mount to avoid clutter on the floor. All the departments are equipped to the most modern standards with the best and latest equipment so as to be able to provide the best end-to-end treatment to our patients. State-of-the-art cardiac cath labs, the latest robotic hybrid OT, ECMO, interventional pulmonology, high-end orthopedics, general and bariatric surgery, epilepsy monitoring unit with robot-guided epilepsy surgery, neuro monitoring, navigation, the latest lithotripter, urology laser are just some of the arrows in our quiver. Our primary focus, though being the local Vellore people and Indians at large, we are working towards attracting overseas patients as well. We have started an office in North Sudan in Khartoum. We're in the process of tying up with the governments of Oman and Seychelles as well. In all, Naruvi Hospitals is more than a hospital. It is an experience.
A very good Sunday morning to all. We are here for another edition of the Hindus webinar as part of the Wellness series. Today's edition is presented by Naruvi Hospitals, and the topic is Advancements in Interventional Radiology. We often hear or know of cancer patients undergoing radiation sessions or radiologists doing the various X-rays, MRIs, fluoroscopy, CT scans, ultrasounds for diagnosing diseases. But what is IR or interventional radiology? It is a way for doctors to treat problems such as vascular anomalies like bleeding or tumors. They do so by performing minimally invasive procedures with the help of medical imaging guidance. They diagnose and treat a wide range of conditions in the body affecting the brain, kidney, knees, legs, except the heart. By, by inserting various small tools such as catheters or wires and treat the disease at its source. In many conditions, interventional radiology can be used instead of the conventional surgery, and it also eliminates the need for hospitalization. From a subspecialty of radiology, IR has become one of the fastest growing branch of medical science. It is a separate stream that is dubbed as the future of medical surgery in another 2 decades, perhaps. To share more details about IR and the technical advancements, we have a panel of interventional radiologists with us today. And I would like to introduce them to you now by one, and each of them will be giving their presentations. We start with Dr. K. Naveen Kumar, working as consultant interventional radiologist with Naruvi Hospitals, Vellore. He underwent training in whole body interventions, including neuro, head and neck, thoracic, hepatobiliary, peripheral uro, and gynecology in Delhi. He has multiple paper and case presentations in national and international conferences. His special interests are neurovascular and peripheral interventions. A very warm welcome to you, Dr. Naveen. And it is over to you for your presentation on the subject itself, advancements of interventional radiology.
Can I share it, my screen?
Yes, please.
Good morning, everyone. I'm Dr. Naveen Kumar. I'm consultant intervention radiology at Naruvi Hospital. I'm going to talk about advancements in intervention radiology. First of all, what is intervention radiology? It's a subspecialty of radiology in which minimally invasive procedures are performed using image guidance like ultrasound, CT, and fluoroscopy. These are the machines we use: ultrasound, CT, and fluoroscopy. It can be purely diagnostic. It means we can use for only diagnose a disease, or it can be a treatment purpose. These first two images are diagnostic purpose. This is called biopsy. We use a small biopsy gun to take sample from a cancer tissue and will diagnose the disease. This is also a diagnostic brain angiography. We can use the blood vessels in the brain like coronary angiography. These two are therapeutic procedures. We use balloons and stents to open a blocked blood vessel. This is also a therapeutic procedure. We use coils to close the aneurysm. These are the common organs treated by IR: brain, lung, liver, kidney, GIT, uterus, prostate, blood vessels, and bones. I'll talk about few common diseases and its treatment by intervention radiologist. First one is varicose vein. These are very common diseases. And these are enlarged, tortuous, bluish veins appearing in the legs and feet. This commonly seen in people who are standing for a long time, like police, teachers. It will start with a small spider veins and it will become like visible veins, causes cramps, restless, swelling, ulcer, and discoloration. It causes blood clots later. These are the various stages of varicose vein. Initially it starts with a small varicose veins and it will leads to non-healing ulcers. What we offer is we do varicose vein ablation. We put a small probe like this inside the varicose vein and we'll close it with the laser energy. It's a daycare procedure we do in the morning and we discharge patient in the evening. It's a very less invasive, incision-free, quick healing and speedy recovery. This is the before procedure and after procedure. Next disease is blood clots. It can be in the artery or veins. If it is in the vein, it causes DVT. If it is in the artery, it causes acute limb ischemia. It means it closes the blood supply to the organ, so it causes discoloration of these organs. If it is a DVT, it causes pain, swelling, discomfort. If the clot move to the chest, it causes chest pain and breathing difficulty. This is a patient with DVT of the left leg. You can see the swelling in the left leg. Next is arterial disease. It's cholesterol deposition in the blood vessels causing narrowing of the blood vessel. You can see the yellow color cholesterol deposited in the blood vessel. It causes reduced blood supply to the organ and causes gangrene, ulcers, nail atrophy, hair loss, and pain. What treatment we offer is mechanical thrombectomy for clot removal. It can be in the arteries or veins. We are using a small tube like this and we suck the thrombus from the clot from the vessel and we clear it, so it will increase the blood supply. For arterial disease, we use balloons and stents to open a blocked blood vessel and it will increase the blood supply to the organ. Next is bleeding. Bleeding can be from anywhere in the body, like lung, abdomen, kidneys, intestines. Common cause of lung is tuberculosis in India. What we do is we go into the bleeding site and we use metallic coils like this and we close the site of bleeding, so we'll stop the bleeding. Next common disease is thyroid nodules. Thyroid nodules are solid or fluid-filled lump in the neck. These are commonly seen in women, and most common thyroid nodules don't cause symptoms. If it is very large, it causes swallowing difficulty, breathing difficulty, voice changes, and hoarseness of voice. This photo is showing a thyroid swelling in a patient. What we do is radio frequency ablation. It's a thermal ablation technique. We use a small needle like this and we insert in the nodule and we burn the tumor with radio frequency pulses. It's a very minimally invasive procedure we do in the daycare. It reduces the tumor size and compressive symptoms and cosmetic problems. We can avoid the thyroidectomy and its complication. Patient have to take thyroid tablets after thyroidectomy. Next common disease is liver cancer. It's the fourth most common cancer in men and eighth most common cancer in women. Common causes are chronic liver disease, alcoholism. Liver is a vital organ involving in the body metabolism. These are the symptoms of liver cancer: loss of appetite, nausea, vomiting, itching, abdomen swelling, yellow eyes, pain in the abdomen, and weight loss. What we do is microwave ablation. It's same like thyroid ablation. We ablate the liver tumor and we use a small needle and we put inside the liver tumor and we'll burn the tumor under the ultrasound guidance. We use up to 10 centimeter tumors. We use multiple needles. If it is small tumor, it can be cured completely and we can avoid the major risk of surgery. Next is uterine fibroids. These are non-cancerous growths in the uterus that can develop during a woman's childbearing years. This photo is showing a uterus with multiple fibroids. These are the common symptoms of uterine fibroids: heavy menstrual bleeding, periods more than a week, pelvic pressure, urinary symptoms, constipation, leg pains. What we do is uterine artery embolization. Uterine arteries are the blood supply to the uterus. What we do is we go into the leg vessel and we'll reach the uterine blood vessels and we put a small tube like this and we use the medicated particles and we close the blood supply to the fibroid, so it will shrink by its own. It's a minimally invasive procedure. We preserve the uterus, early pain relief. We can preserve the fertility. They can go for pregnancy. This is a painless procedure. We can do in the daycare. We do in the morning and we discharge in the evening. We can avoid the surgical complications of the uterine removal. Next common diseases is osteoarthritis of knee. It's commonly seen in elderly population. Most common joint problem affecting the knee joint. Prevalence is 22 to 39% in India. It's more common in women than men. Common symptoms are stiffness, pain, tenderness, swelling. What we do is genicular artery embolization. It is for pain relief. It's like same uterine artery embolization. We go from the leg vessel into the knee joint and we block the abnormal blood supply to the knee joint. So it reduces the pain up to 65%. People who are not willing for knee surgery and not fit for surgery because of any cardiac problem in any other issues, they can go for this. We do in post knee replacement patients also who are with pain. It can be done in daycare. Next is hemorrhoids. Hemorrhoids are piles. These are swollen and inflamed veins. The rectum and anus causes discomfort and bleeding. It's a frustrating problem, impacts on patients' psychological, social, and physical well-being. These are the common symptoms: bulging tissue from the rectum, soiling of underwears, anal and rectal itching, rectal bleeding, and anal pain. We do hemorrhoidal embolization, same like previous technique. We go from the leg vessel and we'll reach the hemorrhoids and we'll close the abnormal vessels. Clinical success 65 to 97% we do for stage 1 to 3 hemorrhoids. This is very minimally invasive procedures. Next is brain aneurysms. These are the bulging or ballooning in the blood vessels in the brain. The aneurysm can leak or rupture. It causes life-threatening bleeding. This photo showing a small bulge in the brain. Risk factors are smoking, high BP, drug abuse, excessive alcohol use. These are the symptoms of aneurysm rupture, like thunderclap, headache, stiffness of neck, blurred vision, loss of consciousness, confusion, seizures. These are the different type of treatments for aneurysms. This one is called coiling. We use metallic coils to fill the abnormal aneurysms. This is also type of coiling. We use a stent to hold these coils in the position. These two are advanced technique recently developed. This is called flow diverter. It's a special kind of stent we put across the aneurysm and will divert the blood supply, so it will shrink by its own. This is also a kind of flow diversion. It's called contour. Thank you.
Thank you, Dr. Naveen, for that very exhaustive slide presentation. We
Thank
will
you.
now move on to our next speaker, Dr. CPS Chauhan. He is the vascular interventional radiologist, director of radiology with JP Hospital in Noida, Delhi NCR. Dr. Chauhan has over 21 years of experience in radiology and interventional radiology. He has advanced training in IR from SGPGI Lucknow. He has been a DNB teacher for over a decade and is invited to major national and international radiology and IR conferences. He has numerous papers published in national and international journals to his credit. Dr. Chauhan's areas of interests include peripheral vascular intervention, including aorta, hepatobiliary intervention, and all oncology-related interventions. He will now talk on BPH. Dr. Chauhan, over to you to explain it in detail.
Very good morning. I'm Dr. CPS Chauhan, and I'm a vascular intervention radiologist working at JP Hospital in Noida. So I'll be talking about the benign prostatic hyperplasia, which is generally termed as a BPH. So it is a very common disease. First, we have to see what is BPH. BPH is the non-cancerous growth in the prostate gland. And what is the prostate gland? It is a male gland which is situated below the urinary bladder and above the urethra. So what happens, urinary bladder in any patients, it stores the urines, and through the urethra, the urine pass out to the outer sides. So whenever these glands increase in size because of the age, because of any disease, it causes pressure on the urethra. So there's problem with the urinations. So when it is a non-cancerous growth, it is called as BPH. And how common it is? It is very common. And at the age of 50 years, it is estimated 50% of populations, male populations, they are affected by this disease. But with the advancement of the age to suppose 70 years, 80% of populations, male populations, they will be affected by this disease. That is a different thing. The rate of affections categorized in the minor, the symptoms may be very minor, less symptomatic than very severe symptomatic categories. So treatments goes according to the how much the patient is symptomatic, whether it is in the category of very less symptomatic, moderately symptomatic, and very severe symptomatic. So thing is how we make a diagnosis of BPS. So clinical diagnosis is very important. It is very easy. Patient's presentation is like frequency. Any patients who has to go for the urine on a regular interval time, that is called frequency, and then the urgency. You are feeling like you want to go to the urinations, you want to go to the urine, but not able to pass the urine properly. So these are the symptoms, prime symptoms of benign prostatic hyperplasia. And then the third thing is the nocturia. Nocturia is in the night, you have more urge to repeatedly go to the toilets, and but you are not able to pass the urine. So these are the symptoms of the benign prostatic hyperplasias. And then sometimes a patient had very gross symptoms like they have incontinency after when the urine passed involuntarily, and sometimes in severe category patients they present with the complete retention of urine, means they are not able to pass the urine. They come to the emergency, and then we have to put a urinary catheter to pass the urines. So usually these are the symptoms which are associated with the BPS. So how we make a diagnosis? Diagnosis is very important. First, clinical basis, on the ground of clinical grounds. Diagnosis is very easy. And we ask for a test that is called ultrasound kidney, uretary bladders, and prostate. So it is a KUB ultrasound with the prostates. So this seal the diagnosis in all the patients. We ask for to see in ultrasounds the pre-void, how much urine you have in the bladder, and after passing the urine, that is called post-void, how much residual urine is there in the bladder. So, and then we also see in ultrasound how much the volume of the prostate, how much prostate, how large is prostate gland. Suppose it's 60 gram, 80 gram, this all comes in ultrasounds. So diagnosis is very easy only by doing a scan, ultrasound scan of kidney, uretary bladders, and prostate. Sometimes we ask the patient to go for the uroflowmetry. Uroflowmetry is just to see patient is sitting in a chair and in a machine, and then they ask to void, they ask to pass the urines. So we see the flow, we see the volume, we see the rate. So on basis of these calculations, then this diagnosis of and the involvement of the urethra by the enlarged prostate is made. So when diagnosis is made, and believe me, most of patients, they are in the milder category, they just only want reassurance. So by reassurance, asking them to be active, control your diabetes, and be very active in the life. So these diseases can be handled very well. And after that, in moderate category, most of patients they do very good on a single oral medications. We give them a single oral medications. These medications, they relax the bladders, and patient is able to pass the urines. And most of the patients in these BPS category with these single medications, they do very good for a very long lives. But patients who needs active treatments, patients who have very severe symptoms, very frequency, urging nocturnia, or when they believes this disease is affecting their quality of life, so they required a very active treatments. So active treatments we have right now, we have two kind of treatment. One is traditional, that is called surgery. In surgery, our urologist colleagues, they do surgery. Multiple methods are there. Surgery like transurethral resection of prostate, which is called TURP, which is very common all over the world. Then there's laser surgery also done by the urologist. But all in these surgeries, patients are being admitted in the hospitals, and these surgeries are being done under the general anesthesia. So what is the latest advancement? What we do in cases of BPS, we offer the patients prostate artery embolizations. So idea is shrinking the size of the glands, so patient will be able to pass the urine. So in these patients, these group of patients, we do prostate artery embolizations. How we do prostate artery embolizations? The prostate arteries, we go from the radial artery, from here, radial artery, we pass our micro catheters, we go to the body, and we go to the prostate arteries right prostate artery and then the left prostate artery. In both the artery, we put some agents which blocks the arteries, which decrease the flow into the prostate. And within 1 week, the size of the prostate started decreasing in size, and volumes of the prostate get decreased. The same thing which is being done by the surgery, same thing in by different vascular process, we are offering prostate artery embolisms. So how, if we make comparison, how it is good in comparison to surgery? First thing is, if you see the medical data, the long-term data, the long-term outcome of both the things, whether we go for a TURP surgery through the urethra or we go prostate artery embolisms, both are equally effective. It has been proved in the medical literatures. But how this is good for the patients? This is minimally invasive, no need of admissions. We admit the patient in the morning. We do transradial prostate artery embolizations, and by the evening, patient is being discharged. Even after when we do prostate artery embolizations, after 1 hour, we ask patient, you can eat, you can walk, and within 3 or 4 hours, usually we discharge the patients. There's no need of general anesthesia. There's no need of any cut. There's no complications, no major complication associated with the prostate artery embolizations. So in that way, if you comparison with surgery, it is very good. And many times, many patients who are not fit for the surgery, they also come for these kind of prostate artery embolizations, who have very large prostate, who are bleeding from the urethra. So even in those group of patients, they don't have any options other than the prostate artery embolizations. So this is a new thing which is coming up, and we are trying to make education to the patients. Think about yourself, think about your disease, how you want to get treated. So this is under new techniques to treat the prostate artery embolizations. At our setup, we are doing it regularly, prostate artery embolisms, with very good results. Then what are the complications? There's no complication, as I said, doing the prostate artery embolizations. There is no risk associated with the prostate artery embolizations. Mobilization of patient is very fast. It is a minimal invasive surgeries, and it's basically a day care surgeries. So this is all about the BPS. What are the symptoms? Symptoms is frequency, urgency, and nocturia, and maybe urinary retentions. How we make a diagnosis? We make a diagnosis using a simple ultrasounds, and how we treat the patients. There are different kind of treatments, but yes, nowadays we are moving to the prostate artery embolizations, very minimal and very effective vascular intervention radiology process. That's all from my side. Thank you.
Thank you, Dr. Chauhan, for that very detailed explanation. We now next move on to our final speaker of the webinar, Dr. Anshul Jain. He's the consultant neurointerventional radiologist at JP Hospital, Noida. He has over 13 years of experience in radiology and interventional radiology. He has advanced training in interventional neuroradiology from All India Institute of Medical Sciences, Delhi, with several papers published in national and international journals to his credit. Dr. Anshul's interests are endovascular treatment of intracranial aneurysms, flow diverter stent treatment, cerebral arteriovenous malformations and fistulas, acute stroke interventions, and spinal interventions. His presentation is on neurovascular diseases and the interventions available. Over to you, Dr. Anshul.
All right. Good morning, everyone. So I think I will share my experience regarding another branch of the medical science, that is the neurovascular diseases, where the treatment has been revolutionized by the intervention radiologist. I think I will share my presentation. Yeah. So I think neurovascular diseases, most of us must be aware or must have heard that someone in their family or some of their relative has suffered a stroke. So what is a stroke? Stroke, it is the third most common cause of death right now in our country. It is the most common reason of disability. Approx 1 in 4 people who suffer a stroke, they die within 1 year. And out of them, maybe 30 to 50% patient, they don't regain their functional independence. And what WHO estimates is that by 2050, 80% of stroke cases in the world, they would occur in low and middle income countries, mainly India and China. So this disease, it has such a high prevalence, especially in India. So what is a stroke? Stroke is just simply a sudden loss of brain function. We all must have heard about heart stroke, that there is a stoppage of blood flow in the heart. Similarly, there is a brain stroke, or you can say brain attack, just like a heart attack. So basically, there are two kinds of stroke. One is a ischemic stroke and another is a hemorrhagic stroke. In ischemic stroke, what occurs is there is a stoppage of the blood flow within the brain, leading to sudden loss of function of the brain functions. The second is a hemorrhagic stroke, in which there is a bleeding within the brain and there is a sudden rupture of the blood vessels within the brain. So how to spot a stroke? How a normal layman should spot a stroke? Because it is very important for them to understand that they are having a stroke, or for a relative to understand that someone from in their family is suffering a stroke and they should rush to hospital immediately. So there's an acronym which is known as FAST, FAST. So if you decode it, what is F? F is basically a weakness in the face. It can be weakness on the right side of the face. It can be weakness on the left side of the face. So how to spot it? Ask a person to smile. If a person is smiling normally, he's okay. He's maybe not suffering a stroke. But if there is a weakness on one side, then there is a chances that he may be suffering a stroke. Second is A. A stands for arm or leg weakness. If there is a sudden onset weakness in the hand or leg of a person, that means he is suffering a stroke. Third is S. The S stands for speech difficulty. If the person is not able to speak normally, if there is a slurring in the speech, that means again he is suffering a stroke. And what is T? T stands for the time, because when a person is suffering a stroke or a brain attack, time is very important. When you spot a stroke, you should rush immediately to the hospital as early as possible. Mostly it is important to rush between 16 to 24 hours. More earlier you go to the hospital, more better the chances that the patient can reverse a stroke. So now, what is the new revolution in the field of stroke, which has been, invented by intervention radiologists? So it is a mechanical thrombectomy. I think you all must have heard about there is a stenting, or when you go to the hospital, you're suffering a heart attack. You go to the hospital, the doctors or the cardiologist, they say you that there's a blockage in your heart. We open a heart blockage and your heart attack can be reversed. Now, similar thing happens in the stroke also, which was not there in the medical field 10, 15 years back. But now it's a revolutionary treatment for the stroke. If you are suspected that you are suffering a stroke, you should immediately rush to the hospital. The doctors there in the emergency department, they will do a CT scan or MRI to spot a stroke. They will do your angiography to see where there is a blockage in the blood flow in your brain. And suppose you are having any blockage of the blood vessel in your brain, there is a procedure which is known as mechanical thrombectomy, which is done by intervention radiologists. So they can do it. So what is mechanical thrombectomy? Mechanical thrombectomy, again, it is a minimally invasive endovascular procedure. That means, what does it mean? It means that it's not an open surgical procedure. It's a minimally invasive procedure done through a minimally invasive 1 millimeter incision through your groin. And through this process, we can help to remove the blood clots in the brain, which are blocking the blood flow to the brain. So who are the candidates for mechanical thrombectomy? Again, there are many aspects on which we decide that the patient requires a thrombectomy or not in case of stroke. Most important of them is the time window. So what is the time window? In what time you should reach the hospital so that we can do a mechanical thrombectomy? Nowadays, on the basis of medical literature, we do this procedure in the patients up to 16 to 24 hours of starting a stroke. If you reach earlier, the better the results will be. Okay, so if you reach the hospital within 3 hours, the result of doing this procedure will be better compared to reaching the hospital in 16 to 24 hours. So how is the mechanical thrombectomy performed? So in this way, here you can see that the surgeon or the intervention radiologist, we go through a small incision through the groin, we reach your blood vessel. Through this blood vessel, we reach all the way into your brain blood vessels. And there in the brain, we take a thin hollow tube, which is a microcatheter, through the part of the brain in which there is a blockage. And there we put a stent, we take a clot out with the stent, we take the stent out, and then we are able to again re-establish the blood flow in the brain. So what happens? Like some people ask, what is the recovery after mechanical thrombectomy? Whether the patient will become a normal, will be able to reverse the paralysis? Yes, it's possible nowadays that we can reverse the paralysis if you are able to come to the hospital early. Suppose if you come to the hospital within 2 to 3 hours, there is a very less brain damage, and then we are able to open the blood vessel. Then yes, the reversal or the stroke paralysis can be reversed. Again, it depends on many conditions, the patient's overall condition, the severity of the stroke. And sometimes it takes at least a couple of days or weeks or even a few months for the patient to come back to your normal neurological status, that is the patient can be able to walk and resume his life independently. So what is the benefit of mechanical thrombectomy? Again, it's a greater efficacy. It is very efficacious treatment. It has been proven in the medical literature. If the patient undergoes this procedure within a very early time window, the patient will have a shorter hospital stay. Patient can recover his neurological function. And again, if you compare the overall cost, it is very cost-effective procedure compared to not doing this procedure. This is one such example here. If you can spot this person has a blockage in the right side of his brain, here we go inside the brain. This thin line you can see, we went inside the brain through the groin. We take out this clot. Here you can see the red clot which is there, which we have taken off from the patient's brain. And again, we have successfully reopened the blood supply to his pain. To his brain, and this patient recovered his paralysis. The patient was completely paralyzed before this procedure. Once we did this procedure, his paralysis recovered. Of course, it depends on many other things, but this is just one example. Again, few of the treatment that the intervention radiologists do to prevent the stroke. I have talked about, when you're suffering from a stroke, how can we reverse the stroke? These are some of the treatment that we do to prevent a stroke. Suppose some person is having a blockage in his blood vessel, but he still doesn't suffer from a stroke. If we are able to find out that he has some blockage in his blood vessel, we can open this blood vessel through the stenting. This procedure is known as carotid artery stenting, and we can prevent a future stroke happening to that patient. What is the second kind of stroke which I talked about? That is the brain hemorrhage. Okay, the first one was when there is a blockage of blood supply to the brain. Second one is when the patient is having a brain hemorrhage. There are many kind of hemorrhage which occurs in the brain. One such kind is a subarachnoid hemorrhage. It's a specific type of brain hemorrhage which occurs due to the rupture of the brain blood vessel. And there is a formation of a brain aneurysm. What are the symptoms? The patient will have sudden severe headache. It will be his worst headache of the life. The person can have some swallowing problem, difficulty in vision, loss of coordination, or the patient can lose his consciousness. So how can an intervention radiologist help in such cases of a brain bleeding? So in such cases, we can detect the cause of the brain bleeding. There is a bulge in the brain vessels, and we can go inside that bulge and we can put some coils inside it without opening the skull. We go it through the, again, minimally invasive route. We stop the blood supply in the brain, and then we can help in the recovery of the patient faster. This is another such way. In this, we can put a stent inside the brain vessels to stop the blood flow from the ruptured aneurysm. This is another such example which we have done. This patient presented with a brain hemorrhage. Here you can see the bulge in the brain blood vessels. We put some thin coils, metallic coils inside his bulge, and here we were able to stop the bleeding from his brain. So that's it. This was just some of the example which I shared, how the intervention radiology has revolutionized the treatment of a brain stroke or neurovascular diseases. Thank you.
Thank you, Dr. Anshul Jain, for that explanation. And I would request all our attendees to send in their questions to the panel. And as we take them along, I would, to all you doctors, I would really like to ask, what is this? I mean, if you could just explain this basic difference between radiologist, interventional radiologist, and vascular interventional radiologist, because if I'm a patient and I don't know anything, how do I understand I have internal bleeding or any perforation, and then whom do I go to? I mean, how do I decide that? Because all of you said in your presentations that the patient should immediately rush to an IR, but as a patient at home, if something happens, how will I know?
So I think I will start first.
Yeah, please.
So basically, there are two kinds of diseases which the patient should understand. One is emergency diseases, like I told you, like a stroke or any kind of bleeding. It can be bleeding from the mouth. It can be bleeding from the abdomen. It can be bleeding in the brain. So these are kind of emergency diseases, you know. So in such cases, the patient should not go to OPD or there. They should directly go to the emergency, you know, if they recognize the symptoms. And from the emergency, I think they will be directed to the intervention radiology. Suppose the patient is suffering from such diseases. Another set of diseases are the elective diseases, which are not the emergency diseases. Like I think Dr. Naveen and Dr. Chauhan, they have shown the presentations. It can be if the patient gets to know that he is suffering from some prostate problem. He is suffering from some problem of the brain or the leg blood vessels. He is suffering from varicose vein. These all are the terms which normal public is normally aware of, that I have a problem of varicose vein, I have a problem of thyroid, or I have a problem of prostate. So in such cases, the patient can directly find a intervention radiologist near to their hospital or wherever they are staying, and then they can go directly to their OPD, and then they can seek the treatment option from the intervention radiologist.
I don't know. I also feel that there is maybe perhaps not so much awareness about IR in our country. Please correct me if I'm wrong. So, and also, like all of you also mentioned that there's a higher incidence of strokes for in India. India leads or is kind of shows many high incidence of various diseases. So, in that kind of a scenario, on one hand, we don't have much awareness about IR, and on the other hand, we have the diseases incidence going up. So I would like to also ask you, are all our hospitals adequately equipped with these kind of, either it's a stroke clinic, or I mean, where does a common patient go?
Also,
So again, I think, see, the scenario is now changing very fast, especially if I talk about India compared to scenario 10, 15 years back. 10, 15 years back, India was seriously lagging in terms of the specialist who can treat a stroke, or in terms of the intervention radiologists. They were very few in number. And most of the time, suppose if a patient was having a stroke, they were being managed medically. There was no active treatment at that time, 10, 15 years back, to reverse the stroke. But now the scenario is changing. More and more intervention radiologists, or the person who can treat a stroke, you can do the treatment to reverse the stroke. They are nowadays getting trained, and many of them are now coming to the cities, to the tier 2 cities, or you can say the peripheries. And I think maybe probably in next 10, 15 years, the more the number of intervention radiologists or the doctors who can treat the stroke, they are increasing. So more and more availability, and I think it will increase further. But right now it's limited. Most of the numbers is concentrated in the tier 1 cities or the major metro cities. The tier 2 cities, few of the cities, they are now having the doctors who can do such kind of treatment. But I think in the near future, we will have more number of doctors as the more and more people gets trained.
Okay.
second,
Okay, I'll start taking a few questions also. Renu Bharti is asking that all the procedures that you have mentioned in your presentations, do these give permanent solutions to the ailments?
yes, in most of times it gives a permanent solutions, like in cases of surgery. So any ablations, sometimes what happened, different diseases, different type of protocols of treatments. Sometimes there's a reoccurrence of diseases. Like suppose Dr. Naveen had said varicose veins, ablations for the varicose veins. They have number of recurrence to say how much is varicose vein thermal ablations, RFA or laser treatment is effective. It is effective up to 97%. So we have to see up to 3% of the patients, they are coming back with the same kind of symptoms, a recurrence of the disease. So in those cases when there's high risk of recurrence, so when we do compare it with surgery, earlier surgery was done for the varicose veins, recurrence rate was as high as 20%. But with use of these endovenous therapies, whether it's a RFA or microwave or laser ablations, the recurrence rate has come down to up to 3%. So I guess that is the advancement in medical sciences. But yes, definitely any disease virtually can come back. It has been established in the medical literatures what are the percentage of patients who get a recurrence, like Dr. Ansur do stroke thrombectomy in the futures, they have to be cautious. They are on treatment, so they should not occur again. So all the parameters has been taken care of. Patient should not getting the disease back. But yes, they can get, there is chances of recurrence, but recurrence rate is very, very low when we treat patients endovascularly in comparison to surgery.
Dr. Naveen, you talked about aneurysms and your procedures. So somebody's asking that the thin metallic coil which is placed, when does that get removed?
No need to remove it. We
It's a
don't
permanent.
remove it. It's a permanent treatment.
Okay, okay. And Dr. Chauhan, is there a kind of a redo treatment also possible? Like when there's a bleeding and aneurysm is done. I mean, any of we could take it. Whether we could also kind of.
Most of times, like an aneurysm falling in brain, it is a permanent treatment. It is the end of the treatments. Most of times, it is there's no recurrence, nothing like that. But yes, in other part of body, like in cases of when anyone is bleeding from the bowel, like colon or intestine or lungs, yes, it depends on the patient's conditions. How bad is lung conditions? Sometimes there's chances of recurrence, but again, I would say that recurrence rate is very low, very low. And like in cases of lung, when the patient is presenting with the hemoptysis, which is blood from the lungs, there's no other standard of care. Only we have to embolize the artery. That is the only way to do it. Yes, there's recurrence, but recurrence rate is very, very low, very, very low. Patients whose lungs are good, only small area of infections who get treated. In those patients, it is 100% curable. But yes, again, in any these kind of bleeding, they do recur sometimes.
And are these conditions manageable with medicines or always the surgery is required?
Most of times when it is life-threatening bleeding, when because of the bleeding patients hemodynamically unstable, means his BP is going down, he's not maintaining his oxygen saturations because of BP is getting downs. So at that time we have to do the embolizations. Small bleedings, minimal bleeding leak. The first line of management is medical management. We try to manage the patients on the basis of the medical managements. So we give some injections, the bleeding should stop. But if it is a life-threatening bleeding from any part of the body, so it has to be treated. But that is not in the case of the brain. A small bleeding even can be catastrophic in the brain. So it has to be handled in like an emergency conditions, but not other part of body. If the patient is having one or two episode of bleeding from the intestines. So usually in initial investigation being done, things are tried to be maintained by using medications. But if it is not controlled or if it is hemodynamically unstable, it is cause it may costing dangerous to the life. Then we have to do the endovascular surgery, interventional. We have to do interventions and we have to embolize those arteries. Or sometimes patients comes with completely blockage of the artery in the leg. There's no flow is going to the leg, and foot is going to get the gangrenes. Even in those patients, we have to open the artery, we have to do the angioplasty, we have to put the stents. So it's always severity of the patients, how much severity is in the patients. So, but initial treatment is always medical management if it is not an emergency condition.
Dr. Naveen, you spoke about the uterine fibroids and the role of IR. So, at what age, what is that age group IR can play a role in? Like, because it can happen in younger women, girls also. So, is there any age group for that?
Usually it will be like 30 plus years. It's like childbearing age only we do. Post-menopausal, no need to do it that level also no need. But childbearing age who are reserved for pregnancy and we do for them, it is very large tumor, then we can do it.
Dr. Anshul, maybe you'll have to repeat the repeat what you already showed in the presentation. Dr. Abhishek Chogle is asking how to prevent strokes.
See, so there are quite few common risk factors which every Indian, many of the Indians have of having a stroke. One of them is a modifiable risk factors and other are non-modifiable. So modifiable risk factors are commonly if the person is having a diabetes, the person is having a hypertension, the person does smoke. So most of these are modifiable risk factors. So if you have diabetes, you have to strictly control your blood sugar. If you're having hypertension, you have to strictly control your hypertension. If you are smoking, then you have to definitely quit your smoking because all these diseases and your lifestyle, they increase the chance of having a stroke. Another one risk factor is a sedentary lifestyle, which is very common in nowadays. The persons we are doing stressful jobs, and most of us have a sedentary lifestyle. So this is again a risk factor of having a stroke. So we have to be active. We have to do some kind of exercise either in the morning or evening, some kind of activities. We have to remain active. We have to cut down on our smoking. We have to cut down on our salt intake and our consumption of oils. And you have to mainly control your cholesterol and all. So these are the common risk factors which we all have. And if we reduce all these risk factors, there is a chance that we are able to reduce our stroke risk by more than 50% if we control just these simple risk factors.
There are a couple of little technical questions. Ganesh Kumar is asking, in case of radio frequency ablation of thyroid swelling, how can we preserve the parathyroid glands and protect recurrent laryngeal nerve damage?
We use normal saline to separate the tumor from the normal tissue and the nerves, these parathyroids and all. So we can avoid the injury to those who will avoid it usually.
So, Dr. Naveen is saying that before ablations, because it is a thermal ablation, it generates heats, so surrounding structure can be damaged. That is the questions. And then there's and during these thyroid, there's a one recurrent laryngeal nerve, which is from which we are talking, and that is the nerves of the larynx voice box. And if you see thyroid, now question is, if you see thyroid surgery, if you ask surgeons, see what is the chances of damage to this recurrent laryngeal nerve, because once this nerve is damaged, patient can't speak after surgery. So and then you compare with the thyroid ablations techniques, how much chances of getting these nerves damaging. So if you compare the both modality, there's a gross difference. When we do ablation of the thyroid nodules, the damage of the recurrent laryngeal nerves is less than 0.5%. Virtually, there's no chance of recurrent laryngeal nerve damage or parathyroid gland damage. Only damage is, it is not a surgical process. We are just burning the lesion. So before burning, as Dr. Naveen said, we create a saline chamber outside the thyroid, so that energy which we are giving to the this tumor, this thyroid nodule, it is only into the only confined into the tumor. It is not spreading to the anywhere except this tumor. So that's why chances of damage to surrounding structures is minimal, and I will say there's no chance virtually of damaging recurrent laryngeal nerve. And then second thing, if you see anatomy, it is toward the esophagus. We know the anatomy where this nerve lies, so we don't tend to go to that side, going that side and burning that area. We just keep safe from that area. We just are doing our work far from that area, because it is being done under ultrasound guided. So all the time we are in control, we are looking at where we are working. So chances of these secondary complications are nearly 0% in thyroid ablations. Same question you can ask from a surgeons who are doing surgery. What are the chances of recurrent laryngeal nerve damage after this surgery for such kind of diseases? So aim is minimal invasive and without any significant complications. So that comes the role of vascular intervention radiology in these kind of diseases.
So there's a related question about how efficient is CT guided radio frequency liver ablation, and what is the maximum size of tumor that can be burned?
See, nowadays, all the liver tumors, yes, we do local therapies by the vascular radiologist. It is now established. There's no nothing like a second opinion or these things. So a question is, what is the maximum size of tumor treatments? So for the ablations, thermal ablation, whether we do microwave ablations or we do radiofrequency ablations, now we have multiple techniques to burn these tumors. So for these tumors, size should be not more than 3 centimeter. That is our criteria. Size should be not more than 3 or 3.5 centimeter. Above that size, burning is done like a different thing that is called TACE, transarterial chemoembolations. So in that treatments, we go to the liver artery through the angiography route, and then we burn the tumors. But when size is less than 3.5 centimeter, then we do either RFA or microwave ablations. And second thing is, it is not CT guided. Most of the time it is ultrasound guided, because liver is well seen by ultrasounds only. So when we see in ultrasound, if the lesion is seen in ultrasounds, so it is a dynamic process. We see an ultrasound and we put our needle into the tumors, and then we ablate it. So question is, when the lesion is very small in size, or it is some location where we are not able to see clearly on ultrasounds, then we take the help of CT scan. So in both way, we take help of ultrasound or CT scan. And for thermal ablation, size criteria is strictly 3 to 3.5 centimeter. Above that size, we do same patient TACE, that is transarterial chemoembolations.
Dr. Anshuljan, maybe you could take this. Is there a limit to doing thrombectomies? Like if there are multiple vessels are affected, so like how many can be done maybe?
So basically, what happened used to happen 3-4 years back, that we were doing mechanical thrombectomy in stroke in the patients who are having a single vessel involvement, and mainly it was a large vessel involvement. Vessels means, if you technically say, it's a middle cerebral artery or a brain ICA. But nowadays, with the advancement in the techniques, with the advancement in the hardwares which we are getting nowadays, we can do thrombectomy in the multiple brain vessels also nowadays, and we can go to the small vessels which measure maybe 1 millimeter or 2 millimeter blood vessels. So nowadays we can do thrombectomy multiple blood vessels also, and not only limited to the large blockages, we can now open the small blockages also.
So it is basically IR is also giving a very accurate diagnosis. So
Yeah.
that is why you are able to
Yeah, so basically, I
reach better. Yeah.
combination of it, diagnosis and the treatment. So basically, we diagnose, and through the methods which we diagnose, it can be ultrasound, it can be CT scan, it can be fluoroscopy, X-rays, or the angiography. Through the same route, then we treat it also. So basically, we are treating under navigation. You can say under guidance. We are doing it. It's not a blind procedure.
Right. Dr. Naveen, what would be the role of IR in gangrene? You mentioned varicose veins and all, but there's a query about gangrene and pain in legs.
In gangrene, if it is due to peripheral arterial disease, then we'll go inside and we'll remove the thrombus from the blood vessel. So we do mechanical thrombectomy to remove the thrombus from it. So we'll clear it and we'll increase the blood supply. If it is peripheral arterial disease causes gangrene, then we have to do balloon plasties and we have to put a stent. If it is above the knee blockage is there, we put the stent also. If it is below the knee, we can't put the stent. We do only balloon plasties to open the blood vessel as much as possible, so we can increase the blood supply. So it will stop the gangrene progression, and we can little treat that gangrene part.
Somebody is asking about the success rate of genicular artery embolization.
I must say that, I mean, you should,
No, sir.
see, the success rate is, first things, what is genicular artery embolations, and which category of patients get benefit from these patients. Now, if you see the osteoarthritis of knee, the majority of patients, they are in the category of moderate arthritis, where they don't require total knee replacements. So in those group of patients, but they get a frequent attack of joint pain, acute conditions like effusions, joint pain, synovial thickenings, and pain in the knee joints. But looking at their scenario like MRI or X-ray, their mobility is good, joint space is good. They don't require at present total knee replacements. So those patients who had repeat in the moderate arthritis, the significant effusion, synovial techniques, they are the candidate for these genicular artery embolizations, not the patients who are in the severe category, whom we can ask you better to go directly for TKR, that is total knee replacements. Now, question how successful it is. It is not for the successful. It is not to reverse the arthritis of the knee joint. It is just to minimize the symptoms. If we do genicular artery embolizations, his patient's repeated attack of pain, swelling, effusion will be subsided. So we are not treating that osteoarthritis will be reversed. It will get corrected, or it will be completely gone. So there's no success criteria for this thing in genicular artery embolization. It is just for controlling the symptoms of the patients. So till his joints are not permanently not damaged, completely damaged, till then we are making patients free of symptoms. Then how effective it is, since it is a very new techniques, long-term data is not available right now. Maybe line down the line 5 year or 10 years, the long-term data will be available. Then we can say how many patients they get benefit from these results. But yes, initial data, initial patients, it is very encouraging. All the patients whom we do genicular artery embolizations, they respond very well. The pain gone, swelling gone, redness gone, and quality of life is improved. But yes, severe arthritis category patients, we ask them to go for better to go for the TKR, total knee replacement.
Mr. Jaishankar is asking why a clear cell type adenocarcinoma that is treated with all sets of therapies remains notorious and cannot be controlled.
Yes, adenocarcinomas are very dangerous cancers. They are the highly, I mean, the very aggressive cancers. So treatment, it depends ki which part of adenocarcinoma it is. So suppose if it is a confined tumor at one places, so we can treat it locally, like we can burn it. We can do some embolizations like transarterial chemoembolization. We can put some chemotherapy there. But if it is has been spread to the body, suppose cancer is somewhere else, suppose cancer is in the some other part of the body, to say gallbladder, then it has been spread to the body. So then treatment is usually chemotherapy, which is you understand that chemotherapy is given to the patients. So in these group of patients, only role is chemotherapy. There's no local regional therapy. It is a generalized therapy. Chemotherapy is giving all over to the body where the cancer has been spread. So right now, sometimes it is very difficult to treat even by the chemotherapy in the spread cancers, and like these clear cell carcinoma, adenocarcinoma. Yes, they are very aggressive cancers, and many times they don't respond to the chemotherapy. But yes, if we talk about the endovascular treatments, and these kind of patients, we it has right now very limited role in these kind of cancers. We treat mostly tumor which are supplied by the vessels, which are related to vascular tumors and any vascular diseases. Clear cell carcinoma is still being treated by the chemotherapy that or immunotherapy sometimes.
Dr. Naveen, would you like to take this question from Deepak, who says after percutaneous transhepatic biliary drainage, the draining catheter is removed. So is it essential to remove the metallic stent, which is made a pathway used to insert the catheter?
We use metallic stents for cancer patients, so we don't remove that metallic stent. If it is a benign tumor, benign stricture or something, then this gastroenterologist put a plastic stent, so that can be removed, but metallic stent we don't remove.
Okay. Dr. Jain, what will be the IR procedure for hemorrhagic stroke?
Okay.
And also, is there a difference between IR and interventional cardiologist?
I will say that first. The second part, what is the difference between intervention radiologist and the intervention cardiologist? Intervention cardiologists, they treat the cardiac diseases like myocardial infarctions, which is called heart attack. So they are confining to the heart only. and the rest of the vascular part in the body, whether it's a brain, whether it's abdomen, whether it's a chest, whether it's a peripheral arteries, and whether it's a carotid artery, is being treated by the interventional radiologist. Some overlapping is there in some institute, like intervention cardiologists. They also tend to treat the peripheral arteries or to say carotid artery. But if we see the trainings, we are trained to treat, except cardiac, we are trained to treat rest of the body parts. Being a radiologist, we can make a good diagnosis, what is the problem, and we are in good control of anatomical structures. So that's why all over the worlds, apart from the hearts, rest of the body vessels, rest of the organs are being treated by the interventional radiologist rather than an interventional cardiologist. So interventional cardiologists, they are confining to the heart, and rest of the body parts are being taken by the interventional radiologist. First part of question will be by Dr. Ansel only, hemorrhagic stroke.
Okay, so regarding the IR treatment of the hemorrhagic strokes, many of the hemorrhagic strokes, mainly in the younger patients, they are caused by some underlying blood vessel problems. So the patient may be having any brain aneurysm, which has caused the hemorrhagic stroke or the bleeding into the brain. The patient may be having any kind of vascular malformation, or which is called as arteriovenous malformations, or any kind of fistulas in the brain. So these are all the causes of the hemorrhagic stroke. And in such cases, what as an IR we do is that we go through the angiographic route, we close that bleeding vessels. It can be an AVM or a aneurysms or any kind of fistulas, and then we prevent the future hemorrhagic stroke from happening in such patients. So all these treatment for the brain aneurysms, any brain vascular malformation, any kind of abnormality in the brain blood vessels, we as an IR, we treat those vascular problems so that the patient does not suffer a hemorrhagic stroke again.
So, is there any MI protocol, doctor? And somebody's also asking, is fluoroscopy enough for the procedure?
So basically, yes, nowadays the hospital who have established stroke centers, just kind of a MI protocol is in the hospitals. Many such hospitals, like maybe in Dr. Naveen's hospital, in Dr. Chauhan's hospital, my hospital, we have a dedicated stroke protocol there. And whenever the patient comes with a suspected stroke symptoms, we take the patient urgently for an MRI. We do an angiography of the patient, and suppose the patient has any blockage in the brain blood vessels, we open that blood vessel. So yes, in many hospitals there is a dedicated stroke protocol. That's why we say the patient should rush to emergency, and in the mostly in the places who have a IR there, so it's established protocol.
Question was MI protocol, MI, myocardial infarctions. Somebody asked, I guess, MI protocol for the cardiologists only, since they deal with the cardiac problem. So any acute MI, acute heart attack, when the patient comes to the emergency, it's been seen by the interventional cardiologist.
Right. So our time is up. I'll just wind up with one last question about the cost factor. I mean, we have, of course, seen the benefits of interventional radiology procedures. As you said, no anesthesia, no hospitalization, accurate diagnosis. What about the cost factor? Could any of you highlight that?
If we see the cost factor, the initial cost may be high when these kind of procedures being done, because of certain things like hardwares, which are the catheters, which are the stent, which are the embolic agents, which we use. So initial cost factor is very high. But if you see the overall costs into the hospital stay, these minimal invasive treatments, recovery is very fast. ICU stay doesn't require much ICU stays, and many process, they are the daycare process. So in the long run, if you see patients who are being treated as a conventional treatments or being treated by as a endovascular treatments, so if you see the overall scenario, the patient's ICU cost is decreased, patient's hospital bills are decreased. So cost factor at the end of day, it might be less than a conventional surgery. And in many processes, it is the only way to do it. But about cost, long run, yes, definitely. The ICU stays decrease, no require of larger dose of antibiotics, and mobilization of patient from the hospital to the home is very fast. So that's why if in those terms, cost factor is not very high. It is good in comparison to the surgery or to other competitive method of treatments. But yes, initial cost when you do process is high. It's a little bit higher than maybe it's equal or maybe a little bit higher than the surgery. But in long run, it is cheaper than the conventional treatments.
So what is that price range, Dr. Jain? Could you give us? Because I also understand it's not available in the government sector as much as it is in the private sector.
So it depends on the kind of treatment, what we are
Yeah,
dealing
so
with.
what could be the range, like it's a minimum to maximum, average?
See, minimum depends if we are doing a daycare procedures like maybe in the varicose vein, the treatment for the prostate, or maybe the treatment for the fibroids. It can vary from, you can say, around 1 lakh near about, and it can go much higher up depending on what disease we are treating. Suppose, like you say, we are treating any hemorrhagic stroke or any brain aneurysms. In which we use the hardwares, which are very sophisticated hardwares. They're very expensive. So in such cases, the cost can go higher up to, you can say, 3 lakhs, 4 lakhs, or 5 lakhs. But majority of the IR treatments are not so costly. Mostly the range will be around 1 to 1.5 lakhs. So again, if these are daycare procedures, I think they are not very expensive if you compare them to the traditional surgery, because the patient can start working from the next day itself. There is no bed rest. There is no loss of the patient work which the patient is doing. He can resume his work duty from the next day itself after the IR treatment.
So I'll end with this one very interesting question. Somebody's asking that in case of an emergency, brain stroke, will a neurosurgeon be also present in the operation theater?
So it depends what kind of stroke he is having. Suppose if he having a blockage of the brain blood vessels, so it will be the IR who will treat the brain blood vessels. The neurosurgeon will be DEET. Suppose if the patient is having any brain bleeding, and that bleeding, it requires an evacuation, or you can say the surgical treatment to remove that blood clot, then definitely the neurosurgeons will do it. But if suppose there is a aneurysm or any blood vessel related problem which has to be tackled angiographically, so it will be the intervention radiologist who will treat that. So basically, suppose the patients come to an emergency, there is a dedicated team in the hospital comprises of a emergency physician, critical care physician, neurologist, intervention radiologist, and a neurosurgeon. They take as a team decision that who will take the lead in the treatment.
Okay. So, okay, thank you, doctors, for giving your valuable time and inputs to explain the subject of interventional radiology to our audience. And I'm sure they have gathered many takeaways from today's webinar, which was presented jointly by the Naruvi Hospitals and the Hindu as part of its wellness series. Thank you all once again for joining in.
Thank you.